I'm sitting here with Dr. Kat Smith, who is Reader and Director of the Global Public Health Unit in the School of Social and Political Science at the University of Edinburgh. And Kat's hot-footed it down from Scotland to meet us here in Wales. So croeso I Gymru, welcome to Wales, Kat.
Thank you.
And thank you very much for coming to talk to us about your paper, which is in volume 40, issue number 1 of Sociology of Health and Illness, and it's called Understanding Lay Perspectives on Socioeconomic Health Inequalities in Britain and Metaethnography. So I thought we'd start the conversation by talking about how you became interested in this issue, and in particular, is an interesting acknowledgement that you'd done some work with the Samaritans as a prelude to this.
Yes, thanks very much, and thanks for the invitation to do this. So there was two routes to which I got to the point of doing this metaethnography. So one was a kind of a long-term interest in what public think about health inequalities and policy responses that stemmed from all the work that I'd done looking at what policymakers and researchers and advocates think about this issue. And a key issue that kept coming up as a kind of stumbling block was, well, the public don't really understand health inequalities, they don't care that much about health inequalities, it's not something they'll go out and protest about, and they don't support many of the policy proposals that researchers suggest are required. And indeed, when Johan Mackenbach was reflecting on the failure of English approaches to address health inequalities, he pointed to the lack of a democratic mandate. And yet, when I asked people to justify their sense that the public didn't support some of these public policies and didn't understand health inequalities, they often really struggled to come up with any kind of evidence to support that claim. So it was just a kind of general perception, I think, that often comes from a sort of broader media discourse rather than a clear sense of empirically a grounded sense of what the public think about health inequalities and potential policy responses. So I had a desire to do this, and then the Samaritans asked me to produce something, and they gave me a fairly free hand that was exploring the relationship between mental health and suicide and socioeconomic deprivation. And so I decided in that initial review to focus on qualitative accounts of how people themselves explained that link. And then for this paper, I slightly broadened that out, so it wasn't just focusing on mental health and suicide. But so it was a paper really intended to synthesize existing accounts from qualitative studies that other researchers have done, asking people to themselves talk about health inequalities and explain this link between socioeconomic deprivation and poor health.
Okay, so I mean, one of the things when I first read it and it really intrigued me was this idea of almost an acceptance that there's a dissonance between lay understandings and the kind of research consensus in this field. And I have to say I'm as guilty as anybody on this, because I remember teaching this kind of idea 20 years ago in medical school. So did you find that there was a resistance to you challenging that issue?
I haven't so far, and I think this idea partly stems from a general kind of consumption of what the media report about public preferences and what we see in elections that people vote for and not. So it's informed by something, but also more quantitative data on this. It's pretty limited, but where it exists, where people are asked to identify in a fairly narrow way the existence of health inequalities, that research suggests that the public aren't identifying health inequalities, and indeed, I recently commissioned a survey that asked some very similar questions to questions that had been asked 20 years ago, and the results were almost identical, suggesting there wasn't an increased public awareness if you frame the question in very particular ways. But I think it's quite a different issue when you're asking people to reflect on their own sense of what impacts on their health and health of their friends and family and local communities. And I think as soon as we start to reflect on it, of course, people have an understanding of all of the different pressures that are impacting on their health, and there's no reason to think that they wouldn't. But the issue is we haven't connected these two different ways of looking at health inequalities.
Interesting. Now you took a particular approach to the issue by undertaking a metaethnography.
Yeah.
Can you say a little bit about why you decided to do that and what that entailed?
Yeah, so I mean, my aim was to really bring different qualitative studies together that tended to be quite small scale but often very in-depth, providing really insightful knowledge about public understandings of health inequality, was to bring them together and synthesize them. And I've previously done a lot of systematic reviews where you spend quite a lot of time making sure that you've systematically identified everything on the topic, and then there's a very kind of rigorous and systematic approach to bringing that information together. But I felt that that kind of approach, and I'm one of many people to feel this, doesn't necessarily do justice to the kind of in-depth insights that you get in some qualitative research. And it also tends to strip context out, whereas context is really key for understanding the relationship between place and how people think about health and health inequalities. So I turned to metaethnography, which was developed a few decades ago and has been pretty widely used to synthesize qualitative research. And I guess the key difference is, I mean, it's a very in-depth approach. We stuck to the first stage of a systematic review process in terms of trying to identify all of the literature that existed on this topic. But the key difference is in terms of when you're bringing the studies together, you're focusing very much on synthesizing the data rather than providing a kind of thematic overview of the different papers and publications.
I mean, one of the things that impressed me in the paper was the kind of detail you went into, not only in going through the studies and categorising them, but in your producing diagrams that gave the reader a very nuanced understanding of what was going on in these different papers. And one of the things that came out was that you were focusing on first order accounts and second order accounts. Could you say a little bit more about how you did that?
Yes, so in a metaethnography approach, I mean, the original people who developed the idea, and many people since have made this distinction between first order accounts, which is the accounts provided by the people involved in the study, so the original data, and then the second order accounts, which is the accounts of the authors who've written up this paper that you're now synthesizing. Now, we actually really struggled with that distinction, and we're not the first people to do so, because of the constraints of word limits, particularly in public health literature, I think. Often authors use a very small extract to make a very specific point. So in choosing that extract, they've made a very conscious decision to draw that out of the wider data set. And we didn't have access to the wider data set. So it felt like even the original extracts were really a second order form of data, because it was the author's decision to include that and not something else. So that's why we ended up treating them collectively, which I think a few other authors have done for similar reasons.
So it's an interesting commentary on the limitations of the publishing within some of the disciplines as well, isn't it, I think?
Yeah, it is, and obviously there's moves at the moment towards kind of big data sets and having data made available so that other researchers can access it. But I think the moves are it's much more complicated for qualitative research when it's full kind of interview transcripts or ethnographic data that might identify people. So I think it's unlikely that we'll move towards that.
Okay, well the other thing that impressed me obviously was the richness of the findings, and you've organised those in different sections, and focusing initially on lay understandings of the ways in which socioeconomic circumstances impact on people's health. Could you say a little bit more about what you found under that heading? So, I mean, I think it's true that there's some really good studies in here which gather together really great data, and obviously that's due to the other authors. Yeah. So I just wanted to acknowledge that. Some really great studies in there. And the voices of some of the participants come out really strongly. But I guess the things that came out were that people's own understanding of health inequalities and the various impacts of socioeconomic deprivation on their health are very similar to researchers' understandings. So they often talk about things like lifestyle behavioural issues like alcohol or poor diets as being basically a distraction from the difficulties of a very stressful life and working environment. So there's a really nice quote in there by one participant who talks about cakes and sweets being kind of the pills of life that just kind of
take you away from everything for a moment and give you a moment of pleasure in between things. And alcohol, tobacco, drugs and food were all referred to remarkably similarly in that sense. So that obviously coheres with researchers on health inequalities who for a long time have been talking about the limitations of lifestyle behavioural approaches. It also really brings to the fore the kind of importance of employment, and employment not just for individuals but the kind of wider community setting of employment, and a sense of what opportunities there are for oneself and for one's family and friends, and how that impacts on people's kind of everyday sense of hope or hopelessness in some cases. And so there's some really good papers in there that, where they've got great data of people reflecting on what happens when you get large-scale industrial closures. And then there's also a really nice paper in there that's looking at more recent accounts from young people growing up in Teesside, and demonstrating the kind of low-pay, no-pay cycle that they're constantly engaged in, and some of the very poor working practices that very obviously impact on health. So there's that. And then another aspect that also really coheres with the research on health inequalities is there's a lot of emphasis that people play on the sort of psychosocial pathways that link material circumstances, so things like your house, your work situation, and experiences of health. So a lot of emphasis on people's sense of stress and then how that impacts on them directly and then indirectly through decisions to kind of maybe drink alcohol or do engage in some of those unhealthy lifestyle behaviours that are about distracting you from these current circumstances and so on.
Yeah, there is interesting ways in which people talked about factors that have the potential to amplify inequalities or illness, but also work in different ways. So some of the studies refer to anger actually being a positive thing, and in another way being negative. So there's a kind of ambiguity in the kind of direction of different effects. Is that something that you found striking?
Yeah, I thought that was really interesting. So obviously if you're looking at this from the point of view of policymakers, or particularly at a local level, thinking what might we do to ameliorate health inequalities and the impact of socioeconomic deprivation on health, you'd be thinking about what factors might kind of reduce that impact. But I think that the difficulty there is, we identified a series of factors that across the papers were seen to amplify the effects or were seen to mute the effects, but those were often the same kinds of factors, just as you said. So anger was one of those that could work both ways. So anger could obviously lead to stress, it could lead to poor decisions, and those could have lasting impacts on someone. But it could also be a motivator for somebody deciding that they were going to get involved in their community and try and change things and work together, or set up some kind of people talked about setting up, particular community groups and so on, and that had then had a really positive impact on them. And the same for critical life events. So people losing a family member, sometimes to an issue related to drugs or alcohol, sometimes through suicide, because suicide rates are obviously associated with socioeconomic deprivation. So there is a relatively high proportion of participants in these various studies have experienced losing a friend or family member through suicide. And those kind of impacts, again, people talked about them. And sometimes it's the same individuals who had experienced something quite similar at two different points in their life. And at one point, it had led to some poor decisions, and in one case to going to prison for a while. But then later on, it had been a motivator for change and moving their life in a positive direction. So I think that makes it quite difficult for people trying to intervene to think about what might be helpful and what not. Yeah,
thank you. Another striking thing that you talk about in the findings is this paradox that you refer to about people not acknowledging, although having very nuanced and complex understanding of the kind of contextual and material factors that affect inequalities, not acknowledging or taking that step to make a link with health or health inequalities.
Yeah, I think it's really interesting. So what the studies show, and some of the people who've written these studies have talked about this paradox before, so people like Jenny Pope, So they show that people have a very sophisticated understanding, or at least people who've experienced socioeconomic deprivation, which most of these studies exclusively focus on, have a very good understanding of how that deprivation and disadvantage is impacting on their health and the health of their friends and family. But when you ask people to talk about health inequalities as a kind of, maybe in a more abstract way, but so the inequalities that exist between their neighbourhood or their community and another neighbourhood and another community, people are very resistant to that idea. And I think, and the studies show this quite well, but it's actually fairly obvious when we sit and reflect on it, that it's quite a disempowering thing to acknowledge that health inequalities, which you probably can't do very much about, exist and are likely to impact on the health of you and your loved ones. And this, we're talking about people who are already being disempowered in various different ways. And so I think often the resistance to talking about health inequalities, either as a more abstract concept or kind of specifically between your community and another, I think the resistance to acknowledging that comes from a resistance to being disempowered and a sense that you want to feel like you have got agency over your health and that your children or whatever aren't going to be impacted negatively by this situation.
And I think you make some very interesting links to the wider literature on shame and stigma and sense of place.
Yeah.
To bring that point home. But one of the things you then go on to do in the discussion is to make some tentative suggestions for researchers, which I found quite powerful at the end. So you made some suggestions about the use of language, for example, and trying to challenge binary oppositions, which is, I think, research often kind of falls into that tendency. Can you say a little bit more about why you kind of arrived at those points?
Yeah, sure. I think it's actually really important because in the health inequalities literature, I mean, I guess one of the findings is that there is actually surprisingly little research that is focusing on listening to what the public think about health inequalities and potential policy responses. I think partly because we haven't been doing that kind of public engagement in our research very much, or not many researchers have been doing it. We haven't actually put that much thought into how the terms that we use and the way that we talk about places and different groups of people is itself quite stigmatizing. And so talking about the poor or poor communities or deprived communities, it sort of seems like an inevitable part of the health inequalities discussion, but it is quite stigmatising, and obviously people resist that. I mean, generally people resist being put into boxes, but particularly boxes that are stigmatised. And being poor in this society at the moment in the UK is increasingly stigmatised, I think. And obviously there's been lots of research just published in this journal which is talking about the stigmatisation of poor health. So you have an understandable, I think, attempt of people to resist this. And if we really want to be engaging people on the issue of health inequalities, then I think we need to be finding ways of talking about it that aren't as stigmatising. It's quite difficult to know what language to use because we obviously do need to talk about health differences, and we need them to be acknowledged, and we need to be clear about the differences between different communities and places that we want to talk about. But I think it's so I don't have any great suggestions about the kind of language that we could use, but I do think there are some terms that we could avoid, and I think we could start having more of a conversation about it.
Well, one of the things you argue towards the end is that there is an ethical obligation on us as researchers to try to limit the negative effects of our research. And I think there's something really tantalising in the last sections of the paper because you argue for a shift in focus of research away from, not another piece of research describing inequalities, but focusing more on interventions. But you talk about a specific approach to interventions. You talk about experimenting with deliberative democratic forms of engagement, and I found that really interesting. But obviously, it's a kind of it's a stepping off point for further research and another paper, I think. But could you say a bit more about what you meant by that and how you might have taken it forward?
Yeah, absolutely. So one of the consequences of this paradox that we talked about earlier, I think, is that there's a sense within health inequalities researchers that we need to do some disseminative kind of work to persuade the public that there's a real issue here. So there's been quite a few innovative examples of that. So really creative things like Claire Bamber produced some football league tables, and various people have produced kind of transport maps that map the health inequalities, and they do get picked up by the media and they get a discussion going about it. So they perform a really important role, but they are at the same time potentially contributing to this idea that there's a kind of a ranking which is stigmatizing for those in the poorer places. And this came across really well in one of the papers that more recent papers included in the review by Mari Mackenzie and colleagues, that's drawing on data from Scotland, where one of their participants is talking about picking up a newspaper and reading about health inequalities and perceiving that or experiencing that as being kicked by the people who are in better off positions. And that really, I was already kind of starting to reflect on this, but that really brought it home to me that I think we need to find different ways of engaging with the public in this conversation. And I got increasingly drawn to deliberative approaches where you're bringing people together so there's lots of different deliberative approaches, but the idea would be that you're bringing people together who have different views to talk about a specific issue, and you're bringing people together with who in some way by attributes represent the community that they're from. So you've got a diversity of age groups and gender and so on. And you bring them together to talk about an issue and to hear from a range of different, they're often called witnesses and citizens' juries or experts in some way. So you might have a local GP or you might have a researcher, various different people to give their accounts of the issue. And then you're getting people to kind of debate and discuss that, to challenge some of what they've heard, and to move towards coming up with a policy response. So it's very much a kind of solution focused approach to engaging with the public. And I think that's really helpful in kind of overcoming some of the issues around stigma and so on. So I have, since this paper, undertaken 3 citizens' juries, which are kind of a form of mini-public that has a form of deliberative engagement. And I have to say, obviously I'll be writing them up in a separate paper, but they were hugely inspiring events where the public that we invited to those 3 juries in 3 different cities really seemed to positively engage with the idea of health inequalities, were really keen to talk about policy responses and had a very active debate about the trade-offs of different approaches. So I feel that that's a really positive way forward.
Yeah, and a very exciting way of taking some of the really important issues that you found in this literature in a practical way that is empowering for people.
Yeah, I hope so. And I'm kind of hopeful that reflecting on that, and I'm hoping that we can do some more of that research, would then help contribute to us as researchers having some kind of learning around language. What terms might work better? What terms are people themselves using in a slightly less derogatory fashion and so on?
Okay. Well, thank you so much for sharing your thoughts and ideas of the paper. I found it a fascinating paper, and it's wonderful that it's part of the journal, and I hope the work on participatory democracy, democratic means is taken forward, and maybe another paper in the future.
Thanks very much.
Thank you very much, Kat.